Samity from Jack Interventions, and I'm at Emory University. And we're very delighted here to have with us at the CVN studio Dr. David Kandzari, who's the Director of Interventional Cardiology at Piedmont Heart Institute in Atlanta. And David has a very interesting paper in the upcoming issue of Jack Interventions entitled Dual Antiplatelet Therapy Duration and Clinical Outcomes Following Treatment with Zotarolimus-Eluting Stents. So let me ask you, David, tell us a little bit about the design of this very interesting study and what your methodology was.
Thank you, Habib. So in the Endeavor Clinical Trials program, we pooled all of the key registration trials involving the Endeavor stent. Most of these were randomized trials, either in comparison to a bare metal stent or to alternative first-generation drug-eluting stents. And among these 2,100 patients approximately, we followed their 3-year outcomes according to their adherence to both aspirin and thienopyridine therapy. Specifically, the Endeavor program was the first of the newer advanced generation drug-eluting stent programs to more carefully ascertain adherence to both aspirin and thienopyridine therapy, given the changes in prescription patterns, given the concerns over the risks of late and very late stent thrombosis. What we identified is that against the background of very favorable safety outcomes of cardiovascular death, of myocardial infarction, of stent thrombosis, and even stroke, we found that whether patients stopped thienopyridine therapy against the background of maintaining aspirin treatment, if they stopped therapy at 6 months, at 12 months, or if they even continued dual antiplatelet therapy for 2 years, their 3-year outcomes of those composite of outcomes like stent thrombosis and cardiovascular death and myocardial infarction did not statistically vary, suggesting that those patients who were adherent after Endeavor treatment to 6 months of dual antiplatelet therapy fared just as well with regard to safety outcomes over a late-term follow-up as patients who were adherent to dual antiplatelet therapy for 1 year or even 2 years.
Okay, so methodologically, you took patients who were on dual antiplatelet therapy for over 6 months, but less than 12 months, and compared them to between 12 and 24 and over 24 months, those 3 cohorts?
That's exactly right. And in particular, you raised 2 important caveats. One is that this is a study of adherence to both aspirin and thienopyridine therapy. Mm-hmm. This is not a study of stopping both antiplatelet agents at any time point. We know that that portends a heightened risk for patients no matter what type of stent they've received. Secondly, we excluded patients who in the first 6 months had either prematurely stopped antiplatelet therapy, who had an intervening event such as a myocardial infarction or a repeat revascularization in which there may be a very solid clinical ground to continue antiplatelet therapy longer. And similarly, we excluded patients who had a major bleeding event within the first 6 months as well, for whom there might again be a clinical rationale to stop antiplatelet treatment.
Okay. So so to summarize then, the primary findings of your study is whether patients were on therapy for just 6 months or up to 2 years, you found similar cardiovascular outcomes, including stent thrombosis and overall cardiovascular outcomes.
That's correct. A principal driver today in clinical practice, of course, after DES revascularization is the concerns of late and very late stent thrombosis. Mm-hmm. We have guidelines that we'll talk about are largely based on consensus opinion, and in part some trials outside of the realm of DES revascularization that have suggested that longer is better. But on the other hand, more recent observational studies and even 2 large randomized trials have challenged this notion that there is a perceived mandate of 12 months or if not a lifetime commitment to dual antiplatelet therapy after DES revascularization. So this again is one of those studies that would challenge that, at least specific to this type of drug-eluting stent, that the patients who stopped thienopyridine therapy at 6 months, and again, this was at their discretion, at the physician's discretion, the exact reasons why we don't know, but they did just as well over late term as those patients who took dual antiplatelet therapy for longer periods.
And I think that's a good point because obviously, because it was at the physician's discretion, one of the things you found was that the groups were not identical and you adjusted for them. For instance, those patients that were on longer dual antiplatelet therapy tended to have more risk factors and other?
Few, if any, studies, to your point, have the fidelity to capture those details that are so common and important to us, but don't necessarily tell us why patients stopped antiplatelet therapy. So we performed a propensity score adjustment model to help balance for as many clinical and angiographic characteristics as possible.
So is it fair to say that for a simple percutaneous intervention with Zotarolimus-Eluting stents, based on the study, you would advocate only 6 months of dual antiplatelet therapy, or do you think that would be too preliminary and these are hypothesis-generating data?
Well, I'll give you maybe two answers to that.
Right.
One is, to begin with, this study, of course, has limitations. This was a retrospective observational analysis of a database that, albeit large, with over 2,100 patients, certainly isn't of sufficient sample size to make definitive conclusions with regard to hard safety endpoints like death, like myocardial infarction, or even outcomes like stent thrombosis. But on the other hand, they are highly suggestive, and they are also very consistent with a larger and yet growing body of evidence, both observational and randomized data, that is suggesting that longer adherence to dual antiplatelet therapy, and in particular for continuing dual antiplatelet therapy for beyond 6 to 12 months, is not necessarily reducing those events. It's challenged the guidelines recommendations that patients should receive at least 12 months of dual antiplatelet therapy. So my opinion, though, is that based on these data, in parallel with a collection of additional emerging data, the recent Prodigy trial being one example of this, a randomized trial suggesting no benefit for 24 months versus 6 months, that again, collectively, these data might challenge the existing guidelines in that 12 months of dual antiplatelet therapy, while it may be appropriate for many patients, shouldn't necessarily be considered an absolute contraindication for a patient to receive the potential benefits of drug-eluting stents.
Well, thank you very much. And this sort of highlights the importance of more individual-oriented, patient-specific therapies. And people have talked about intravascular imaging or other techniques, try to select those patients that can receive shorter-term dual antiplatelet therapy. But with that, David, we look forward to your future leadership and work in this field.
Thanks, Abhi.